Thank you. So I'm in the College of Computer and Information Science at Northeastern, so I'm a technologist. And I'll be talking about a particular technology I've been working on with my students and many clinical collaborators for about the last 8 years for implementing health behavior change interventions. Okay, so what we do is go out and study one-on-one, face-to-face counseling conversations between health providers and patients. So doctor-patient communication, nurse-patient communication, and try to understand all of the verbal and nonverbal cues that go on in these focused conversations. So in the verbal channel, we're looking at things like the therapeutic part of the dialogue, so what's being asked of the patient, what they're being told to do. But we're also interested in the language that's used to build trust and rapport and therapeutic alliance over time. So this is important not only for patient satisfaction, but for promoting adherence and health outcomes, of course. In the nonverbal channel, we're interested in looking at things like the use of hand gestures for conveying information, gaze cues for turn-taking, body posture shifts marking topic boundaries, head nods for demonstrating understanding, facial displays of emotion for compassion and caring. And then what we want to try and do is simulate this interaction with as much fidelity as possible in an automated health behavior change intervention in some very narrow domain. So our attitude is if we're going to have the computer do hand gestures, we have to give it hands. If we're going to have it do facial displays, we have to give it a face. So this is what our systems end up looking like. So this is a virtual discharge nurse character that we developed with clinicians at Boston Medical Center. We wheel this up bedside just before a patient goes home. We download the information from their discharge instructions into the system, and they have about a half-hour-long conversation with this character before they go out the door about their self-care procedures once they go home. The intention is to reduce unnecessary readmissions. So the style of the interaction is the character talks using synthetic speech. That's because everything it says is dynamically assembled from the patient's medical record, questions they just asked, information from previous conversations, so it's all dynamically assembled on the fly. And it's using simulated nonverbal behavior, so it's doing these hand gestures and gaze cues and body posture shifts that we see in face-to-face conversations synchronized with the speech. When it's the patient's turn to say something in these interactions, they'd like to talk to the system, and we'd love for them to talk to the system, but to work reliably, we give them a list of things that they can say at each point in the conversation, and they touch it off of a touch screen. This works very reliably. We can train patients who've never even seen a computer before to use this in about 30 seconds, and then they're off and running for potentially hours of interactions with us. So I'll say that the virtual discharge nurse, we've had to discharge about 200 patients at BMC now. It's a safety net hospital, so patients have relatively low levels of computer literacy and health literacy. One of the things that we always ask the patients is if they would have rather heard their discharge instructions from their doctors or nurses in the hospital, and 70% of them say no, that they prefer actually getting it from the character. So whether that says something about the character or their doctors or nurses, I don't know, but no, but when we ask them why, they say because it provides a much more relaxed environment in which they can get the information that they need and get their questions answered. Okay, so why have cartoon characters talk to people about their health? So I'll give you 3 reasons. The first one is everybody knows how to do face-to-face conversation. So Clayton earlier talked about simplifying the interface and using things that people already are familiar with as intuitive forms of computer interface. This is sort of the ultimate form of that. So everybody knows how to do conversation. If we provide the cues of face-to-face interaction, everybody knows how to interpret those already. And in fact, we see the highest levels of acceptance with patients who have low computer literacy and low health literacy. So this is results from a clinical trial with geriatrics patients. And we see that those with inadequate health literacy actually had the highest levels of satisfaction with the system. Okay, so second reason why having cartoon characters talk to people about their health might be a good idea is we've been particularly interested in looking at providing information to patients with low health literacy. So looking at best practices and how providers explain written medical information to patients, orienting them to the document with hand gestures, using gaze cues for gauging understanding, using simulated teachback, and how we can simulate that in the interface, for example, for explaining written discharge instructions or informed consent documents. And then a third reason is we're very interested in building some sense of trust and rapport and therapeutic alliance. This is particularly important in longitudinal interventions, which has been talked about a lot here today, in maintaining retention and adherence in long-term interventions. So we want the patients to like and trust the character so they'll come back and keep talking to it and pay attention and follow its recommendations. So if you look at human-human interactions and how people build relationships, many of the cues that we use to engender trust are nonverbal in nature. So there's, in addition to facial displays of empathy, there's immediacy cues, which are things like simulating closer proximity, orientation towards the patient, more facial animation, more smiling, more direct gaze, and other cues like that that we can simulate in the interface that would be difficult or impossible to do if we just had a text-based system or other form of GUI. And so in some of our trials, we've actually manipulated social and relational behavior. So we've turned off the social niceties, but left the therapeutic part of the conversation the same, and we find that it actually has impacts on validated measures of therapeutic alliance. So patients do react to this kind of behavior. We've also done other studies where we've looked at making the character more human, for example, by giving it human backstory. So it could talk about the kids it has at home and if I have a spouse last night and where it grew up, and find that patients actually react to this positively and they log in more frequently in home-based longitudinal interventions when the character does this. So they actually like having a human dimension to these systems. Oh, there we go. Okay, so let me show you first couple of minutes of a demonstration. This is a video capture of a first conversation of an intervention we developed for doing exercise promotion for geriatrics patients.
Hi there. To talk to me, just touch one of the options on your right. Hi again, John. Tanya here. Great to see you. We are going to be working together to help you do more walking. How are you feeling today? I am sorry to hear that. Tell me more about how you are feeling. How tired are you feeling? So you can still walk, right?
Exercise, get out there and exercise.
That is a relief. Please get some rest. It's so important to take care of yourself. I am excited about getting started. Today, I would just like to go over what you will be doing in the Steps to Health program, and I would also like to make sure you understand how to use your pedometer.
Okay, I'll stop it there. So we've done a number of health behavior change interventions using this technology, mostly funded by NIH, with a number of clinical and behavioral collaborators. Everything from medication adherence for antipsychotics to breastfeeding promotion. But today I want to focus on one line of research, which is looking at exercise promotion in older adults. So of course, exercise is important for everyone, but for older adults, it's particularly important to maintain mobility, and mobility, of course, is important for preventing falls and maintaining independence. So this is one of the first pilot studies we did a few years ago with patients from Boston Medical Center Geriatrics Ambulatory Practice. So this is a safety net hospital. Half of the patients who were in the study had never touched a computer before. So one thing we were wondering is if we put a touchscreen computer in their home for a couple of months, would they even use it? So we gave them pedometers to wear every day, asked them to have a daily chat with this exercise coach. It's about a 10-minute conversation every day. And what we found is none of them had any problems using it, and they really responded positively, especially to the social dimensions of the interaction. And a lot of the participants really wanted to keep talking to the agent and finding out more about it, in fact. High levels of satisfaction and high level of a desire to continue. This is at the end of 2 months, so wanting to continue using the system. So a lot of them complained when we took it away, actually. And the qualitative interviews, again, a lot of feedback about how much they enjoyed chatting with it, the social dimensions of the interaction and the relational behavior, in addition to the fact that it got them out and to do more exercise. Oh, and a double the amount of walking they were doing relative to a control group who were just given pedometers and log sheets. So on the basis of this, we did a follow-on study funded by NIA, in which we had 263 patients from the geriatrics clinic and other primary care clinics at Boston Medical Center randomized to either the intervention group or a control group who were just given pedometers. So everybody got a pedometer to wear for a year. In the intervention group, we gave them a tablet computer to take home for 2 months and had them have a daily conversation with the exercise coach at home. And then following the 2 months, they brought the tablets back, and all of them brought them back. We had a kiosk in their waiting room that they could interact with to have maintenance conversations with the character whenever they came in for a regularly scheduled appointment. And the results from this are, so these are, the top 2 lines here are the intervention group, the bottom 2 lines are the control group stratified by health literacy. So we saw significant differences at the 2 months point following the intense intervention, and it's somewhat washed out, so it's just trending towards significance by 12 months. Another study we did that came out of this is looking at exercise promotion in patients with Parkinson's disease. So this is with Nancy Latham and Terry Ellis at Boston University. So for patients with Parkinson's, exercise is important for increasing and maintaining their mobility. But we were wondering if they would use the system, again, if we put it in their home for a month, ask them to wear pedometers, would they actually use the system and get some benefit out of it? So it was a quasi-experimental single-group study just to see, looking at acceptance and feasibility. But they all completed the study. They had very high levels of actually interacting with the coach daily. They followed the recommendations for walking very closely. And we weren't expecting to see significant differences, but we actually saw differences in clinically meaningful outcomes in this group.
Were the patients treated with a pharmacologic agent during that time?
I don't think so.
Because there is now an agent that is effective, including your always Parkinson's.
So my understanding is that it should still be used in conjunction with exercise regimen, though.
Some of them were on it and some of them weren't, etc.
Okay. And then another project that we did that was a follow-on from this is looking at doing a linguistic and culturally tailored version of the system. This is for an older adult Latino population in San Jose, California. This is in collaboration with Abby King at Stanford. And so in this case, we put a touchscreen computer kiosk in a community center and had a 4-month-long intervention where folks could come in. We asked them to come in twice a week and have a chat with a virtual coach. They could do it in English or Spanish. The social and relational dimensions of the system were tailored specifically for the Latino community. And here again, we saw significant differences between the intervention group and a waitlist control. And then just want to briefly mention work that we're doing now is to scale this up somewhat. So based on feedback from participants that they wanted to have more social chat and more ability to do things with the agent, in collaboration with WPI and funding from NSF, we're building a system that can not only coach exercise and wellness, but does things like scrapes the web for weather information and sports scores, so it can have extended social chats with them about current events. It has games that they can play, and it will have sensors so it can detect them as they walk by and try and draw them in, engage them in interaction. So as opposed to the other systems that are a single 10-minute long conversation, this is a persistent agent that's always running and always available to provide social support when they need it. So some of the design studies we've been doing are following around volunteers who visit isolated older adults to find out what sorts of activities they engage in and what kinds of things they talk about. And Wizard of Oz studies where we put a system in elders' homes and then have one of our research assistants in the lab who are remote controlling the agent to characterize the kinds of dialogue that older adults would want to have with these agents. Okay, so barriers. There have been many barriers talked about today, but one I'll reiterate that was just mentioned is on the research side, I'm particularly interested in looking at how do we maintain really long-term engagement. So I've had systems in use by older adults for about 2 years of daily conversations, but once you get past the thousands of conversations, so what can you keep doing to keep people coming back and using a voluntary use system is a big challenge. So in conclusion, simulating human behavior, human conversational behavior is one way of building an intuitive interface that is accessible and provides you additional channels for increasing engagement and retention in healthcare interventions. And that's the team. Thanks.